Good afternoon, everybody. So today's CCR from the Department of Medical Oncology. The topic that our department will be discussing is turning the tide, navigating the complexities of dual transplants. Normally, whenever a patient has had a single transplant, doing a second transplant of any type is always a complexity. So, doing a transplant after a solid organ transplant becomes even more challenging. And today, from our department, initially Dr. Prabhat, then Dr. Chitrakshi, and supported by the pathology team and the nuclear medicine team and radiology team, will take you through this case. And this has been done under the guidance of our faculty, my colleague, Dr. Ranjit Sahu. And then Ranjit Sahu will close in the end with his expert comments. Over to you, Prabhat.
Thank you. Thank you, sir. Good afternoon, everyone. So we'll be starting with our case, which is navigating the complexities of dual transplants. So our case is a 38-year-old male who is an IT professional. He had the comorbidities of hypothyroidism. He is also a renal transplant recipient 24 years back. He was transplanted because he had end-stage renal disease secondary to a posterior urethral valve. The donor was his mother, and for the last 24 years, he was on immunosuppression with 10 mg of prednisolone each day and 100 mg of azathioprine each day. So he was doing well until he developed a few hyperpigmented skin nodules. He had some weight loss, which was not exactly documented. He had shortness of breath on exertion and had bilateral scrotal enlargement. So as we can see here, he had these hyperpigmented nodules on the skin. On clinical examination, he was pale. He did not have any icterus, cyanosis, or pedal edema. There were no hypertrophied gums or tremors in the hands. As seen earlier, there were hyperpigmented nodules present. The abdominal examination revealed a mass in the right iliac fossa, which is consistent with the transplanted kidney, and both the testes were enlarged. Other than that, the systemic examination was largely normal. So in 2023, he had a essentially normal complete blood count, as can be seen on the left. However, when he came to us, he had developed pancytopenia. All the 3 cell lines were suppressed. HP was 8.7, total leukocyte count of less than 2000, and platelets at 1.2 lakhs. So an initial differential of a post-transplant lymphoproliferative disorder, post-renal transplant was kept, and in line with that, the immunosuppression was slightly reduced. Initially, as told earlier, he was on 10 mg of prednisolone each day and 100 mg of azathioprine, which was reduced to 10 mg OD of prednisolone and everolimus 0.5 mg BD. However, there was no clinical response with respect to the lesions. At presentation to IRCH, an ultrasound of scrotum was done, which revealed bilateral testicular enlargement and altered ecotexture with increased vascularity on one side. So, suspicion of infiltration of the testes by the disorder, PTLD, was considered. I would like to call my colleague from nuclear medicine to discuss the baseline PET scan, which the patient had on 1st of July 2023. Over to you, sir.
This is the whole body FDG PET-CT study done on 1st July 2023. The first image is the maximum intensity projection image showing increased FDG uptake in the mediastinum, bilateral supraclavicular region, left shoulder joint region, and in the bilateral testis. The first row images are the fused PET-CT images and second row images are the CT images. The first image shows the metabolically active mediastinal mass, lymph nodal mass. The second image shows the skin and subcutaneous lesion, and the third image shows the metabolically active bilateral testis.
Thank you. So, as summarized, that he had FDGA with testicular involvement, a chest wall involvement, and a mediastinal involvement. Considering this, we did a bone marrow evaluation. The bone marrow was suggestive of 63% blasts, which were essentially MPO negative. So, we considered an acute lymphoblastic leukemia. The bone marrow flow cytometry was sent, which was positive for early T cells marker like CD3, CD2, and CD38, and negative for CD1A, CD4, and CD8. With this picture, a diagnosis of early T precursor ALL was made. The skin biopsy, which was done from the hyperpigmented lesion, was reviewed, and on review, we had infiltration by atypical immunopositive lymphocytes, which were positive for CD3, CD5, CD7, and BCL2. Please keep in mind BCL2 positivity. I will come back to it later. While they were negative for BCL6, EBV-LMP, CD4, CD8, and the other markers as shown. So a differential of PTLD with a suspicion of T-cell lymphoma was considered. After discussing the findings and taking all the reports such as the bone marrow flow cytometry and other investigations, a final diagnosis of early T precursor ALL was made with the involvement of testes and skin. So in a nutshell, so far we have a 38-year-old man, a renal transplant recipient 23 years ago, hypothyroid, with hyperpigmented lesions over the skin and bulky testes, with pancytopenia, skin biopsy and flow cytometry suggestive of ETP ALL, baseline cytogenetics 46XY, a baseline FDG PET scan showing involvement of lymph nodes, testes, and skin as discussed, and the baseline CSF cytopathology was negative. So with this diagnosis, we started him on the following treatment. So from 27th of July, he was started on Holzer induction, which included 6-MP, cytarabine, cyclophosphamide, oncovin, and L-asparagine. At the end of induction, the bone marrow showed a morphological response and the MRD status was negative. An ultrasound was also done at the end of induction, which still showed involvement of testes by the lymphoproliferative disorder. After completion of induction, he was put on POMP maintenance from September of 2023, which consisted of prednisolone, vincristine, methotrexate, and 6-MP. He was also taken up for a testicular RT in view of testicular involvement and a prophylactic cranial irradiation because these ALLs have a high propensity for involving the central nervous system. While he was on POMP therapy, he developed the skin lesions which were similar to the ones he had at baseline. At this time, the complete blood count was normal, but since the skin lesions were suggestive of a disease relapse, he was planned for a skin biopsy and a repeat bone marrow evaluation. So the skin biopsy done after that was consistent with the relapse of the disease. At this stage, the bone marrow was still in morphological remission, that is, the blast count was less than 5%. The peripheral smear was not remarkable. However, in flow cytometry, we had 1.6% blasts, which is positive. The ultrasound of testes also revealed no infiltration of the testes by the lymphoproliferative disease. However, there was bilateral hydrocele. So because of MRD positivity, he was started on reinduction from November 23. This time he was given 6-MP, Arasi, cyclophosphamide, and a BCL2 inhibitor, that is venetoclax, was also added to the treatment regimen. I would like to remind everyone that in the baseline, the biopsy which was done showed BCL2 positivity. So after this induction started from 6th of November, a response assessment was done on 1st of December 2023, wherein the bone marrow showed that the disease was in morphological remission. A flow cytometry was MRD negative and skin lesions had normalized. At this stage, we took him up for an allogenic stem cell transplant. So in this case, we screened the potential donors. The one on the left upper was the father, mother, and 2 siblings. And after considering the factors such as age, male sex, and CMV seropositivity, his brother was chosen as a potential donor for the patient. So the brother was a young 36-year-old male who was blood group concordant, CMV concordant, viral markers was negative, and he was a matched sibling donor. So he was chosen as the donor for this patient. The pre-transplant workup which was done revealed a DLCO of 63%. The echocardiography was essentially normal and the GFR was 56 ml per minute per meter square. So with these findings, the hematopoietic stem cell transplant comorbidity index was calculated at around 5, out of which 2 points were contributed by a reduced DLCO and 3 points because of a prior renal transplantation. So with a HCT-CI of 5 and a non-relapse mortality of around 1/4 of the total cases was predicted at the end of a year. So this is the conditioning regimen which we used for this patient. This is the modified FLAMSA regimen, which is a sequential induction and conditioning regimen. So as we can see here, for the induction, we used fludarabine, cytarabine, etoposide, and venetoclax from day -8 to day -5, followed by busulfan on day -3 and day -2. We also had to modulate his immunosuppression at this stage because the patient was on prednisolone 10 mg OD and everolimus 0.5 OD because of the post-renal transplant status. So after discussion with the nephrology colleagues, we took him off prednisolone and everolimus, and the immunosuppression for stem cell transplant was initiated. So we used ATG, F, mycophenolate mofetil, cyclosporin, and methotrexate. So ATG was given from day -4 to -2, MMF was started from day -8, and cyclosporin was started just pre-transplant and adjusted to the value as per levels. A CD34 dose of 10 million cells per kg was used, and a CD3 dose of 196 million cells per kg was given. Post-transplant period was eventful. The patient developed febrile neutropenia on day -2 of transplant, and the source was localized to the urinary catheter-related stream infection, which was managed well with antibiotics. He recovered. He engrafted neutrophils on day +14, which is normal for an allogenic transplant. The engraftment of platelets happened on day +15. On day +44, the patient had a reactivation of cytomegalovirus. The test was positive for 3,200 copies. So he was started on treatment with valganciclovir for the same. On day +60 is when the patient presented to us with his current admission. At that time, he had fever and cytopenias. So EBV test was ordered, which showed that EBV status had reactivated. At this time, he had 3 lakh copies of EBV. So because of that, we reduced the immunosuppression and we gave him rituximab, which is an anti-CD20 monoclonal antibody. An HRCT was done at this point to evaluate fever, which revealed a nodule in the right upper lobe and a nodule in the left upper segment in the left middle lobe, which was suggestive of involvement by a lower respiratory tract infection. For this, he was started on IV antibiotics and supportive care, and antivirals for EBV and CMV were continued. He also developed reappearance of skin lesions as were present on the baseline. So we were suspicious that the disease may have relapsed at this stage, wherein we ordered a skin biopsy, which confirmed that the dermis was being infiltrated by small atypical lymphoid cells, which were positive for CD3 and TDT. So it was consistent with cutaneous relapse of the ETP ALL. A bone marrow was done again on this admission, which showed 6% blasts, which was consistent with a relapse. The histiocytes were increased in number. However, there was no significant hemophagocytosis. So an HLH could not entirely be ruled in here. A flow cytometry was done, which was again positive for MRD status at 3%. This time also the CD38 marker was positive, as was positive at the baseline. So this has therapeutic implications, as we can see in the subsequent slides. So I would like to again invite my colleague from nuclear medicine. Can you please discuss these findings, sir? These are the PET scan findings done in this admission at the time of relapse.
This slide shows the FDG PET CT scan images done in February 2024, that is after bone marrow transplantation and when the suspicion of disease relapse was there. And this is the maximum intensity projection image. And these are the fused PET CT images, and these are the CT images. And as compared to the previous images that is shown previously, there is in these images there is resolution of the mediastinal lymph nodal mass and left pleural effusion, and left anterior chest wall lesion. There is reduction in the left anterior chest wall lesion with metabolic resolution, and there is decrease in the metabolic activity of the testicular lesion. However, in the MIP images, we find there are few focal FDG avidity in the right forearm and in bilateral lower limbs, and with heterogeneous bone marrow hypermetabolism in bilateral lower limbs. So our impression based on this would be disease relapse after bone marrow transplant.
Thank you. So as discussed, the FDG PET was also suggestive of a relapse. So now with this condition, he was again started on chemotherapy as per the modified hyper-CVAD regimen. along with the monoclonal antibody daratumumab, which is an anti-CD38 monoclonal antibody, which was used as at the time of relapse, CD38 was positive, as was also positive at the baseline. Subsequently, a donor lymphocyte infusion with a CD3 dose of 50 into 10 raised to power 6 was also given to the patient on 29th of February. And post DLI, sirolimus was used for immunosuppression at the dose of 0.5 milligram BD. Currently, the patient's skin lesions have reduced. He is afebrile and he continues to be under our care. I will now invite my colleague, Dr. Chitrakshi, to discuss more about this case.
Very good afternoon, everyone. Thank you, Dr. Prabhat, for navigating us through the complexities of this dual transplant. So, I am going to be discussing the development of acute leukemias after a solid organ transplant and how people all over the world have managed it and what complexities and what complications have they faced. So, coming to post-transplant hematological cancers, the life expectancy of patients with solid organ transplants have increased just because of a lot of recent advancements in the same. So, the most significant advancement in a patient of solid organ transplant has been a prolongation of extrinsic immunosuppression. This has increased the incidence of post-transplant cancers, not only because immunosuppression might be causative, but also because it is increasing the life expectancy of these patients. However, the most common post-transplant hematological malignancy is post-transplant lymphoproliferative disorder, and much below this comes non-Hodgkin's lymphoma and Hodgkin's lymphoma. I want you to note that B type of NHLs are much more common than T because the most common causative organism for this is EBV, which will cause a B cell lymphoproliferation, and some of these might be clonally selected. Amongst leukemias also, the incidence will be around 2% per 1 lakh people population who have been transplanted, and most of these patients will develop myeloid neoplasms, especially in patients who have undergone lung and heart transplant because the intensity of immunosuppression tends to be much more in these patients. Acute lymphoid leukemias, on the other hand, are extremely rare and only 2% of all the ALLs would be in a patient who is post-transplant. The pathogenesis of ALL in a patient post-solid organ transplant is multifactorial. The most important one is impaired immune surveillance. We all know that immune evasion is one of the important cancer hallmarks which helps in the development of cancers. So here we are giving immunosuppression to a patient for prolonged periods of time, and this might be causative for development of a malignancy in these settings. Specific immunosuppression, including medications like azathioprine, might be causative because they have direct DNA damaging effects, as I will explain later. Additionally, PTLD is most commonly caused by EBV. However, our patient was EBV negative at the beginning of development of this disease. Coming to the incidence of TALLs, the incidence is derived only from a few case reports and few case series, the largest of which is what I have mentioned here, which is a case series of 8 patients, where what I want you to note is the median duration of development of this TALL has been significantly high, ranging from 6 years to up till 16 years. So similar to a patient who developed ALL after 23 years of age, this is common for patients who are developing TALL after transplant. So what could be the possible etiologies of our patient developing ALL? There are multiple speculations of why these patients would develop leukemias. The first one would be a donor cell transformation. So the renal transplant, the allograft might have some lymphocytes which would have transformed and developed into ALL. However, we had sent cytogenetics for our patient. It was 46XY, and since the donor was mother, the cytogenetics should have been 46XX if that was the case. Non-specific immunosuppression related would be responsible for our patient because he was on intensive immunosuppression for 23 years before he developed this ALL. Specific immunosuppression, azathioprine, is significantly known to cause myeloid neoplasms, and ETP-ALL is also coming from a stem cell type precursor, so it could be related to azathioprine use. Since the disease is developed after 23 years, we cannot completely rule out that it might just be a random event that he developed ALL and he had PUJ, which caused end-stage renal disease in the beginning. So how does azathioprine cause ALL and cause a myeloid neoplasm in patients has been extensively researched. Azathioprine will usually incorporate as a thiopurine nucleotide in the DNA. Rarely, some non-enzymatic methylation of the 6-TG might happen. In a normal patient whose mismatch repair mechanism is working properly, these would be removed and the patient's replication would go ahead smoothly. However, some patients might have DNA mismatch repair deficiency, and these selected clones which are MMR deficient and have 6-thiomethylguanine bases might be selected and might be responsible for development of these leukemias. So, what would be complexities in a dual transplant? Basically, the first thing is that before a bone marrow transplant, we need to give a high dose chemotherapy. In a patient who already has a transplanted kidney from a mother whose age was around 56 years, who would not have a very good GFR, these patients will be exquisitely sensitive to the side effects of this high dose chemotherapy. Hence, as most literature suggests, we should use a fludarabine based reduced intensity conditioning, which was done in our case. Since the patient already has a transplanted organ, there is an increased chance of rejection. And thirdly, GVHD might be more common, especially in the organ that has been transplanted. So we might risk the single kidney that the patient currently possesses. So the most important way to go about these transplants would be to manage the immunosuppression. It becomes crucial because the baseline the baseline solid organ that was transplanted was not HLA matched. It is rarely HLA matched, and current recipient and donor HLA are different. So if we can plan the same donor for both the transplants, it would have a better outcome. Secondly, we saw that if we intensely managed immunosuppression, most of these patients would only develop acute GVHD, which could be managed, and none of them had a fatal outcome or had chronic GVHD. So, for these patients, paramount importance is to manage and personalize the type of immunosuppression. I also want you to focus on the fact that the most common cause of death in these patients in the case series that I had shown before was infection and multi-organ failure, which is no different from a normal hematopoietic stem cell transplant in a patient who has not undergone a previous transplant as well. Why did we choose sirolimus? Sirolimus has both effects. One, it is anti-EBV and CMV in vivo. Secondly, it also has anti-leukemic properties. Thirdly, it also has strong immunosuppressive effect, which will work for prevention of the kidney allograft rejection as well as the donor lymphocyte infusion rejection. So sirolimus might be a game changer in these patients. Before we planned a transplant for this patient, it was very important to know if there would be a difference in the outcomes because he is post-renal transplant. It is confirmed that these patients would do poorly when compared to hematopoietic stem cell transplant in a patient whose indication for transplant was non-malignant. However, there is controversial or close to no data that would show that these patients would perform poorly. So we planned and we went ahead with the transplant of this patient. So the current status of a patient after DLI infusion, which could be a third transplant for him, is that he has a resolution of skin lesions. His kidney functions are doing okay despite the high-dose chemotherapy that he received twice. And once the counts recover, we plan to do a bone marrow to see his remission status. So I would like to call upon Dr. Ranjit sir for his expert comments now.
Thank you, Chitrakshi. So the patient is still not out of the woods, but this patient was a lot of learning to us. And he had been the case of many firsts. He is the first post-transplant lymphoid disorder which presented as leukemia. And in this case, it was an early thymic precursor ALL. And he was the first case, at least our department, when we performed bone marrow transplantation after kidney transplant. And the second thing that is very important in this case is the role of personalized medicine. So there are a lot of hematological malignancies that have been managed with respect to a lot of personalization. At least in this patient, we knew that venetoclax could be active. It was active for some time. And then daratumumab, it is too early to say. In this case and few other cases, we find that this monoclonal antibody, which is actually targeting a CD38 positive clone, and in this patient, that CD38 positive clone was always there. So it could be a useful way to treat such cases. The other thing is, at the start of inception of BMT, all the patient used to be treated with a similar sort of conditioning regimen. We called it as total body irradiation with cyclophosphamide or something like busulfan and cyclophosphamide. They're all myeloablative conditioning regimens. There are patients who are frail enough to receive such high intensity conditioning regimen, which would have resulted in a lot of mortality in such cases. As of today, in this decade, you will get patients which are infirm for a BMT, but with modulation of the conditioning regimen just to reduce the non-relapse mortality in these patients, you can bring down the conditioning intensity and the BMT could still be possible. We never had a very highly successful this thing in this patient, but if you count the successes in simpler terms, did the patient engraft? Yes, this patient engrafted. Did the patient had any sort of organ toxicities? No, this patient didn't have any organ toxicities. But yes, this patient had relapsed. And this was the most important thing in this patient would have been, because this is an immunosuppression sort of disease. Once the patient is immunosuppressed, they're likely to relapse. And GVHD, because of the prevention of GVHD, we do a lot of immunosuppression. That could be a cause in this patient that he had relapsed post BMT at such an early period. And this won't go without any acknowledgements. I mean, this patient had a lot of work, lot of knowledge which was flowing, and lot of effort by all our staff from our center across our departments, and the patient and his caregivers who had been relentless in supporting this patient. That would be my last word. We will be happy to answer a few questions if you have. Sirolimus, it's an mTOR inhibitor. Now, be it CMV, be it EBV, it has got direct anti-CVV, anti-CMV action. Now, as you know, EBV, no antivirals are active with respect to, I mean, there are no direct antivirals for EBV. You have to reduce the cell that is containing the EBV by doing rituximab, that is, it depletes all these CD20 positive B cells. So its action on Epstein-Barr virus is possibly mediated through the CD20B lymphocyte inhibition.
Dr. Ranjit, I mean, this is very commendable, and I was just in awe of
Thank you.
the way it was done. So I have two questions. So why was the mother not chosen as a donor? I mean, since the transplanted kidney was from the mother, that could potentially mean like him being off immunosuppression later. And second question was, if an organ has been transplanted, so are there were anti-HLA antibodies looked into? Because if they are there, then the incoming donor HSC could be at a risk of rejection.
Both these questions are very nice. Now, first question is, we never had a choice, because if you take the mother is a haploidentical donor. I think Prabhat has not gone into detail about the HLA there. If you could see the HLA, mother is a haploidentical donor, and we actually got a mass sibling donor. So we had a fix whether to use the haploidentical donor or go ahead with the mass sibling donor.
But that saves the kidney though.
But
like if the kidney was from the mother.
Yeah, the kidney was from the mother. So if you would have taken mother as the bone marrow donor, she would have been a haploidentical donor.
Yeah, so then the donor immune system changes to that of the mother.
Yes.
And then the kidney is
No, the kidney will be
protected from
safe,
immunosuppression.
but the BMT process with a haploidentical donor, the complications would rise.
Agreed.
So if we could not have got a mass sibling donor in this case, we could have gone back to the mother. We would have taken mother as the donor.
Okay. And any
Second
data
question
regarding anti-HLA antibodies developing after solid organ transplant, which can risk the hematopoietic transplant?
Exactly. So the anti-HLA antibodies, they are relevant with respect to haploidentical donors, because this is a mass sibling donor, so possibility is not that relevant. That's why we didn't do it.
Thank you.
Yeah. Thank you, ma'am.
He said the choice could be mother as a donor. I just wanted to add a point that because the patient would have already developed tolerance to non-inherited maternal antigens. So even if mother was taken, the tolerance is already there. So the mismatched antigens would be taken care of. And sibling being a full match obviously was the better choice. So that's just a added comment to that.
In last SNM meeting in Chicago, there was a lot of discussion about this new approach to do radionuclide-based marrow ablation apart from this chemical marrow. Because this long-term busulfan and other drugs, which cyclophosphamide, which has been conventionally used with doses, their second primary is very high. So the new way is to go with radionuclide ablation, and the dose that MSKCC used is about 1,000 millicurie of antibody labeled I-131.
Yes.
And they didn't say any toxicity. So that is another way to look at into this problem.
So this is called as TMI or TLI. This will come up in a very big way. This is only restricted to few of the institutions. But when we are only irradiating the marrow or the lymphoids, then the organ-related toxicities are going to be very, very less. So those who are high-risk transplants, where when the patients are not that fit to undergo the conventional BMTs, these are the ways to take these patients for BMT. Yeah. Thank you. Thank you very much.